Absolutely. So my name is Ashul Goval. I'm a practicing cardiologist, but also Chief Medical Officer at Story Health. We are a digital health company. We provide technology and services to hospital systems to help them identify gaps in cardiovascular care for patients, and then develop algorithms to help fill those gaps, get patients to goal therapies by providing in-home services as well as in-clinic sort of recommendations to doctors. Yeah. So there's many components, so bear with me here, but we kind of start first by integrating into the electronic health record. That's where most of the data lives today about patients and what their health status is. So we actually look across a population of, let's say, a clinic or a certain doctor, and we say who in this population has a gap in their cardiovascular care. It could be heart failure, maybe uncontrolled hypertension, maybe they just had a heart attack. Whatever that gap is, maybe they're not on the right medications, maybe they haven't got the right testing done. We kind of surface that to the clinician and say, here's a patient who's at risk, who has a gap in care, let's get enrolled in our program. And we get them enrolled, we'll lay out an algorithm based on the patient's status to say, here's what we think the patient needs to be based on where they are in terms of testing and therapies that need to be ordered for this patient. Here's how we're gonna get there over time. You click go, or if you want to tweak it, as a physician, you can tweak it. Once you hit go, that's when we kind of take over, reach out to the patient at home. We provide them with in-home devices, in-home monitoring, as well as start interacting with the patient. We have health coaches to help guide the patients through the process, what they need to be doing. And on the provider side, we start bringing back pieces of data. Not only that home data, but we also start bringing insights from the EHR and outside sources of data like the lab, the pharmacy, really making sure that we are alerting the clinician when they need to take action on something and providing with a recommendation on what that action should be to make sure the patients get to know. Yeah, that's a great question. So we do have a staff of our own, primarily in the form of health coaches. We also will sometimes staff certain clinics with sort of NPs or PAs who can actually help them on the clinical side as well if they need it. But all of it luckily is paid for. So we work off a lot of sort of billing codes such as remote patient monitoring, chronic care management, principal care management. We enable a lot of these codes for the clinic. And so the program kind of pays for itself just on day one. But the real value is kind of the downstream value, right? So we work, for example, in heart failure. We have data that shows we drastically reduce readmissions, so you kind of save that cost. We also increase procedure volume because we capture patients earlier in their disease process, and a lot of patients wouldn't have gotten, let's say, an LVAD or heart transplant. In one clinic, we've doubled their LVAD volume in 1 year. So that's kind of an example of what we could do. Yeah. So in heart failure, unfortunately, you kind of have to follow up forever because these patients are always at risk. Now, there's always obviously different levels of risk for different patients, but certainly that first 90-day period after, and first 30 to 90-day period is really the highest risk for any patient. And not only is it highest risk for admission, but we know that if they do get readmitted, they also have worse outcomes. So there's a lot of risk here just on the clinical side, but on the financial side, there's also some risk too, right? There's now penalties that CMS has put in place for hospitals that have patient readmissions during the time for heart failure, and it doesn't matter what you're readmitted for, it doesn't have to be heart failure. So there's penalties associated with that, but also, frankly, admitting a heart failure patient is just not good business for a lot of hospitals. Many of these hospitals are full, especially nowadays. We're understaffed, we're having to close down wings of the hospital, and so each bed that we have is very valuable. If you have a patient who's sitting there and you just give them IV Lasix and diuresing them, that's not a very good patient to have in the hospital. You don't need to be there. What's better is to have someone who's having a procedure, getting a stent put in, having coronary bypass surgery. That's a much more valuable patient for the hospital, but it's also valuable for the patient because they need to be there. So how do we make sure that that readmission happens? So there's a lot of value just in terms of avoiding that admission for the hospital. Well, everything that we do kind of starts with the American Heart Association and its sort of partners. We start a lot of our algorithms and a lot of our care plans based off of the guidelines, right? That's where the AHA comes in. They've established all the guidelines for heart failure treatment, for hypertension treatment, for lipid treatment, et cetera. And so that's kind of the starting point for any therapy in cardiovascular care. And that's what we really utilize and what we recommend to our clinicians and kind of how we modify sort of care plans for patients. So obviously the science is the one thing. The second thing I think is that the American Heart Association has done a great job in terms of bringing people together to discuss some of these new innovations, some of these new ways of interacting with patients, dealing with patients, and I think partnering with a lot of the companies and a lot of the sort of academics who are here, who are thinking along the same lines as us, has been very useful.